Good morning. Our next speaker is Dr. Thomas Frieden, Director of the Center for Disease Prevention and Control here in Atlanta. We've been very fortunate over the last several years at each of these fora. Tom has agreed to come and give a keynote address. The question that we put to him for today was, where do these problems around refugees and IDPs in places that are broken, violent, and disrupted, where do those fit in the overall scheme of health security? Tom's been a pioneer in the course of this administration dating back to 2009 when he began in this position of driving towards the global health security agenda, the response on Ebola and Zika, lead role on polio. We've entered a phase where these recurrent outbreaks are the new normal. So where does it fit? Where does it fit? And we'll be hearing from Tom, and he has to be out the door by 10 after, so this will be brisk, and hopefully we'll have a little bit of opportunity to hear from some of our speakers here. Tom, thank you so much for joining us.
Thank you. Thanks so much, Steve, for your support, kind words. Thanks for all of the hosts, CARES, CSIS, the World Affairs Council, McKinsey Social Initiative, and anyone else I neglected to mention, sorry. We are in, as I think everyone in this room knows, but too few people around the world know, a unique time. There are more refugees today than at any point since World War II. And currently, there are more than 1.2 asylum applicants in the EU, more than 2 times as many as in 2014. But the density or proportion of refugees and asylum seekers is not always what we would assume or what we might get from the headlines. It is true that Germany has been very forward-looking with this. It is now 1 in 80. In Lebanon, it is 1 in 3. Half of all registered refugees are children. And children, of course, are particularly vulnerable. The more we learn about growing up, the more we understand that adverse childhood experiences can have lifelong ramifications. We know that the risk of death may be 10 to 20 times higher during a journey prior to reaching a place of safety, and that mass movement, lack of sufficient water, inadequate shelter, exposure to infectious diseases, all increase the risk for acquiring communicable diseases. Outbreaks of cholera, measles, tuberculosis, and other diseases depend on local conditions. In many areas, no significant health problems are seen. And there are 2 main determinants of whether there will be a health problem or not. First, what was the health status of the population before they were displaced? And second, what are their exposures and risks during their travel and when they arrive? I recently spoke with a field epidemiologist in Uganda who was investigating a measles outbreak in a rural area that initiated with a refugee population. The refugee population had not been adequately vaccinated, was not adequately vaccinated when they arrived, experienced a measles outbreak, and the local population also was not adequately vaccinated. So you had multiple points of failure. But of course, it's not just about infectious diseases. Diseases such as high blood pressure and diabetes are life-threatening conditions if treatment is not continued. And increasingly, we have more prevalent hypertensive and diabetic and other chronic diseases, and people are separated from their source of ongoing care. On top of all of that, the bottom line is security. The first role of government and the first role of international government is to ensure safety and security. Without that, nothing is possible. And we've now seen horrifying attacks on both civilians and on health workers and on healthcare facilities. I can't say they're unprecedented, because if you go back to barbaric times, they happened. But these are modern times. They shouldn't be barbaric times. We have to take a very strong, unwavering non-negotiable stand against the targeting of civilians, healthcare workers, and healthcare facilities. Now, we have lots of challenges going forward. Challenges in low-income countries where nutrition is suboptimal before a journey, low rates of breastfeeding in some middle-income countries, continued shameful lack of adequate water, sanitation, and hygiene for more than 1 billion people around the world, even without displacement, and nutrition, malnutrition, undernutrition, poor nutrition quality. Especially in middle-income countries, we're seeing neglect of the continuation of treatment for non-communicable diseases. I think we lose sight of the fact that these are life-threatening conditions. And everywhere we see problems with vaccination. Measles and polio are of particular concern. We were privileged at CDC to be able to work quietly with all parties when Syria had an outbreak to end that outbreak. And how important was that? Right now in polio, we're down to only Afghanistan and Pakistan. 7 years ago, it didn't look like India would get over the finish line. They did. Then it didn't look like Nigeria would get over the finish line. They did. Now it's down to those 2 countries, but we have to keep it together. And one of the major challenges there is mobile population. We have areas between the 2 countries where there are 50,000 people who move back and forth each day. That is both a risk and an opportunity. It's an opportunity to provide services and vaccination. It's a risk of spread of disease. Global migration is the new normal. People wonder, why is Zika spreading in this hemisphere now? And the honest answer is, we're not completely sure, but we do know that 2 of the leading drivers are human movement and urbanization. And we do know that, in all likelihood, those 2 factors will just continue to accelerate. So refugees and refugee health is really one aspect of human movement that provides both risks and opportunities to protect and improve health. It's also a critical aspect of global health security. The public healthcare system can break down. That can lead to more unscreened or untreated people. Monitoring and surveillance systems are crucially important. They need to be in place before a disaster, and they need to be robust and resilient enough to survive a disaster. We need to develop systems in countries and support those systems because fundamentally we do 3 things in public health. We find problems as promptly as possible, we stop them as quickly as possible, and we prevent them wherever that is possible. And in the context of refugee health, that needs to be done in the location of origin, to the extent possible during transit, and on arrival. At CDC, we have an emergency response and recovery staff. We have missions ongoing in Greece, Middle East, and Nigeria, were recently completed in those areas. We've provided technical assistance on early warning, alert, and response systems in various countries. We worked very closely with the World Health Organization to simplify surveillance. Complicated data doesn't help. Good, simple data helps. We've also worked on response mechanisms. Increasingly, the new public health is rapid detection, rapid response. That's the approach we're taking to a wide variety of conditions. I just came from the opening session of the Epidemic Intelligence Service conference. It's a 1-week conference at CDC where all of the disease detectives come in and they share their work. It's an exciting conference. And one of the opening presentations was addressing the largest outbreak of HIV ever documented in the US. And this was through fentanyl. I'm sorry, this is through, not, there were 2 presentations. One was fentanyl, one was on Opana. The HIV outbreak was Opana. And we see opiates, for example, acting as a communicable disease in the US. But the broader point is rapid detection, rapid response. That's our approach in public health. That's how we figure out what to do, when to do, whether it's working, what to scale up, what to scale back. We also have a very active refugee health and quarantine program. We provide guidance for panel physicians, for people coming to the U.S. We've worked hard to improve this program, and I think we have some examples that could be useful around the world. I refer to them as triple wins. Take, for example, what we've done with tuberculosis control. The program strengthened the capacity of panel physicians who screen refugees to diagnose and treat tuberculosis. As a result, more people with tuberculosis in countries that are sending people to the U.S. have better systems for diagnosis and treatment of TB. In addition, those individuals are getting cured of their TB, and the U.S. is at lower risk from TB with much lower costs. So we've documented cost saving from this. We've done the same thing with empiric treatment of parasites. We can treat it more effectively, more promptly, more economically, at the place of origin. We're not doing enough. Partnerships are increasingly important. Security is absolutely key. Countries accepting migrants and refugees, as well as those countries that they pass through, need to ensure that public health needs are adequately addressed. The Global Health Security Agenda and the international health regulations provide a framework. They provide a moral responsibility for each country to protect itself, its neighbors, and the world. We also need strong rapid response teams able to go in and address a crisis if it occurs. The risks are to all of us. It's a globalized world. This is not a problem of one country or one region. I'll leave you really with three thoughts. First, that although it's a global problem, we should never forget the individuals whose lives have been uprooted, who bear the brunt of the risk and suffering from migration. It's key to keep their humanity front and center in our minds. The second is that we should never compromise and never stop defending against any attacks on civilians, healthcare workers, or healthcare facilities. These are unacceptable. And finally, I would remind us of what Albert Einstein said in 1929. Nationalism is an infantile disease. It is the measles of mankind. Thank you very much.
We have a few minutes. I'd like to invite Paul Spiegel to offer the first comment or question, and if there's time permits, we'll move to additional questions. Paul?
Thanks, Tom. Paul Spiegel, UNHCR.
Why don't you go up there then? Yeah, because this is being broadcast, and so people can't hear you.
Thanks, Tom. Firstly, also thanks for CDC's leadership. It has been extraordinary, and I must say that what CDC has been doing has really made a difference. One of the areas, though, I wanted to first comment upon and then ask you is the amount of cross-border movement now is extraordinary, and of course it's refugees, it's internally displaced within the countries, but also the economic migrants. The systems that exist are the surveillance systems are often quite poor. And the other aspect that we've seen is that there is a huge political aspect, as you've seen, both in terms of the way the UN is functioning or not functioning. There's been is currently a reform in WHO, but also the ability for the UN or governments such as yourself to speak out and the political consequences. I wanted to get a sense from you of what is possible and how much the U.S. can do on its own and how much the U.S. has to rely on this multitude of partnerships that at times can have significant weaknesses.
Well, I don't think there's a right answer to that question. It's very important for many reasons that the U.S. work in a multilateral framework. It's very important for many reasons that we strengthen United Nations agencies. We don't want to be the either policeman or provider of the world. We want to strengthen global capacity. We want to strengthen national capacity. And we want to have our provision of assistance to be in line with our comparative advantages. So where we can do something that others may not be able to do as well or as quickly, we should do it. But I don't think any government in the world can look at their activities and say, we did this really well for immigrants and refugees and those who are involuntarily displaced. It's crucially important that we improve the national abilities to do this, and most of the burden falls on poor countries in Africa, Asia, the Middle East, where the bulk of refugees are present. It's crucially important that we strengthen international entities that are able to support that, both governmental, public, and non-public. And the U.S. role should be to encourage a more effective coalition. If you look at the analogy to global health security, I believe the single most important thing we can do is establish an accountability framework that will be public, transparent, and accurate, because that will give us the momentum to have public sector and the rest of civil society working off the same page, recognizing where our gaps are, and working together to fill them. Thank you.
Tom, I was very impressed at how much emphasis you put on protecting civilians, health providers, and health facilities. Tell us a bit more on how, in your view, how are those going to be protected better in the future? How are you going? What are the steps that are going to take them out of the line of fire and create more protection in space?
I'm a doctor, not a politician. I will say that part of the answer to how do we protect health workers and health facilities has to be the social norm and the political will. We have to say very clearly that attacks are never acceptable, never, not by any party. And that's something that has to be absolutely inviolable and non-negotiable. So one is what we would call in public health the social norming of it, to be clear of what framework it's in. It's in looking at the quality of medical care. There are certain things which we call never events. They should never happen. There should be systems in place that ensure that even if there's human error, they will not happen. So operations on the wrong leg, for example, are never events. And now hospitals throughout the country have put in systems that don't rely on humans. They don't rely on people to not make a mistake. They ensure there are systems in place so that when humans err, because humans will undoubtedly err, a never event will not occur. And that's what we need to ensure in terms of attacks on civilians, healthcare workers, and healthcare facilities.
Thank you. We have 5 minutes. Zahir, you want to offer a point? I can't guarantee this is going to work, but let's give it a shot.
So just expanding on what you have mentioned, that never event. You know, I'm a critical care specialist, so I'm very familiar with the never events in my hospital. So how come that we, in the public health community, and not many medical organizations are talking about this epidemic in Syria of targeting doctors and hospitals and healthcare facilities, which became the new normal in Syria, and maybe in the future will become the new normal in other conflicts. How come that we're not seeing doctors contacting their senators and congressmen and telling them, you have to do something for that. This is not acceptable for me as a physician in the United States that my colleague in Syria is killed because he's a physician. How come that we've forgotten the Geneva Convention? Is CDC doing something about reporting this, maybe advocating behind the scene and so forth?
Thank you. We all need to do more, and the World Affairs Council, this conference, CSIS, CARE, all of us need to sound the alarm. And I think your question, your statement raises the responsibility that we think about what more we can do. The sad fact is that often in this country, we're a little insular and we're inward looking, and that's not only sometimes unfortunate from an ethical standpoint, but it may be against our self-interest as well, because things that are occurring around the world affect us here. If there's decrease in safety and security elsewhere, there's decrease in safety and security here. Part of CDC is the National Institute for Occupational Safety and Health, and we see violence against healthcare workers in various settings in the US as well. And we need to ensure that it may be from a different frame, it may have to do with people who have other challenges in their lives, but it's a serious issue, not just here, but abroad as well. I have time for one more question, if there is one.
Who would like to? Sir? Tom, one thing. You've been very effective during the Ebola crisis at bearing witness directly to the crises as it unfolded and then carrying the message back to the highest levels. Our president himself was very effective at embracing Nina Pham and inviting healthcare workers when they were being blocked or under threat of quarantine into the White House and celebrating them. Maybe some of those tactics apply in this particular situation. Sir.
Dr. Freeman, one of the biggest problems we have is the P5, the UN. What benefits the US might be going against China, or what benefit China might be going against the other P members, Great Britain or the other. How do we get these people to work together and realize that all their actions have a very significant negative impact on themselves, which is right now reflecting on the refugee crisis?
There is no simple answer to that question. The strength of the United Nations system is that it does have buy-in from all countries. The weakness of the United Nations system is that it requires buy-in from all countries. And the fact is that it is the system we have, and we have to work hard to improve its effectiveness. And the work that you all do in your daily work, the work that you're doing through this summit, is critically important to keep the pressure up to address these last two comments, how to bring home the importance of standing up against violence against healthcare workers and healthcare facilities, and how to ensure that we understand that we have a common bond, a common humanity, not only from an ethical standpoint, but even from a self-interested standpoint. So thank you all for the work that you do, and thank you for having me here today. All the best for a very successful conference.